IVM.
India has a fraction of the doctors and medical professionals it needs, even as healthcare is increasingly becoming a politically important issue. In this context, the Government of India recently passed the National Medical Commission Act of 2019, which overhauled a corrupt and counterproductive Medical Council of India, an institution which was choking the supply of medical professionals. But the new NMC Act is not without its share of controversy, protests, and genuine concerns. Sambit Dash joins us on this episode of the Pragati Podcast to tell us all about it. The Pragati Podcast is a weekly talk show of public policy, economics, and international relations. I'm your host, Pavan Srinath. Our guest today is Sambit Dash, and I must tell you, we've been planning this episode for close to a year, and I'm really pleased that we are finally able to release it. Sambit teaches biochemistry to medical students at the Manipal Academy of Higher Education and is one of the star alumni of the Takshashila Institution's public policy courses. He has written extensively on various policy issues and especially on various aspects of medical education. We'll start our conversation with Sambit after a short break.
Hey everybody, welcome to another awesome week on the IVM Podcast Network. If you are not following us on social media, please make sure you do. We're IVM Podcast on Twitter, Facebook, and Instagram. You know, I have been asking you guys to do this. I think some of you are, but some of you aren't. Have you told your best friend about your favorite podcast? Please make sure you do that as well. You are our ambassadors. If you don't go out and evangelize on our behalf, who's going to do it? So please go out and tell somebody about the podcast you're listening to. If you think there's somebody who would enjoy it, refer them to IVM Podcast and tell them about all the stuff that they can find on our app or on our website or, Spotify, Savan, everywhere you're listening to podcasts, right? Just give it a shot. Also, guys, I'm going to be at Podcast Movement the coming week from the 13th to 16th of August. Podcast Movement is a conference in Orlando where we're going to be doing all kinds of podcasty stuff. So check it out. If you're in the area, please do come by and say hi. If you're not in the area, you can follow along with me by following, my social media in this case is Doshi Amit on most things. On the scene and the unseen, Amit Verma is joined by Pratik Sinha, co-founder of Alt News. They speak about living in the era of fake news, the far-reaching consequences of fake news, and the best way to debunk fake news. The English Premier League has begun and Football Twaddle is back with a new season. This season, they're introducing a Fantasy League episode which airs every Thursday along with regular episodes on Tuesday. Make sure you tune into both of them. On the last episode of this season of the Sponge Podcast, host Ambi Parmeshwaran talks about learning lessons from simple people and shares the story of Goosebuy. On Tech Careers in the New, presented by Accenture, Sheila Aditya is joined by Gopali Contractor, Managing Director, Artificial Intelligence at Accenture. They talk about AI, ways to demystify it, its practical applications, and the career opportunities in this field. Check it out. I think you'll like this show. On Pulyabazi, the Hindi policy podcast, hosts Saurabh and Pranay talk to Mihir Mahajan, a patent strategy expert about intellectual property rights. On The Origin of Things, Chuck narrates a brand origin story that involves priests, traders, and education. Will you be able to guess the brand before Chuck reveals it? Find out by tuning in. On The Habit Coach, Ashton is joined by nutrition and lifestyle coach Rajiv Malhotra. They talk about food substitutes and recipes for a healthy life. And with that, let's get you on with your show.
Hi Sambit, welcome to the Pragati Podcast.
Thank you, Pavan.
We've been talking about having you on the show for quite a while now. And I'm glad that, you've had time to come into our studio today. The topic that we wanted to discuss for quite a while has been actually the same thing. And it's been medical education and the recent legislation that has now passed, right? In 2017, the National Medical Council Bill, I think, first came to Parliament. And finally, it's now passed. It's an act. And this has significant implications for medical education in the country. And at a time when health has become a political subject more and more, both in Karnataka with the protests and the strikes that happened not too long ago, to what's happening now with doctors protesting various aspects of this bill. Can you help us lay out where we are with our medical education today?
All right, Pavan. Indeed, we have been wanting to talk about this topic since a long time. And this is the prime time when we are having this discussion. So to give you a small brief about where we are with medical education. Medical education in our country has been regulated by the Medical Council of India through an act that was passed in 1933.
Okay. So this predates independence.
Indeed. And its newer version in 1956. But since then, medical education in India has been mired in corruption issues, with I guess one of the lowest point being the Supreme Court calling Medical Council of India as the den of corruption.
This was 2010 or so, right?
Indeed. With its chairman, Dr. Ketan Desai, being prisoned for corruption charges in April 2010. I will slightly lay focus on the reason for his arrest at that point.
Okay.
It was for receiving a bribe of 2 crore rupees to recognize a medical college.
Okay.
Now this takes us to one of the major roots of corruption in medical education in the country, where this so-called license Raj or the inspection Raj unleashed by MCI created a lot of disbalance in the whole medical education system in the country. Apart than that, issues of the curriculum being very old and renewal of which happened only recently, which ultimately led to MBBS graduate being produced who was low in competency.
Mm-hmm.
So healthcare in India is facing many problems, some prominent ones of which are the lack of doctors, which we frequently hear about.
Right.
The second would be quality of doctors, which surfaces once in a while where something goes terribly wrong. And all this reflects in the failure of medical education regulator.
Right. It's interesting. I mean, we were recently having a conversation with Pushkar on higher education in India in general, where we talked about everything but medical education. And even there, the striking thing to me was, we can talk about the system, the universities, all of that as much as we want. But you have to think about the teaching profession and, the dignity and the quality of the lecturer and the professor that you come and meet with. And it's sort of exactly the same with medical education, right? We can have the greatest, national healthcare system that we want, but it will not work unless you have good qualified doctors who are available in sufficient numbers to do all the jobs that are necessary.
True. MCI faced this problem of absenteeism.
Okay.
Absenteeism in medical colleges. And proxy presentation also.
Okay.
Yeah. They have been grappling with how to solve this problem, starting from but now they do have biometric attendance, which
for students?
No, for faculty members.
Wow.
Which gets recorded. But anyway, we'll come back to that.
Sure. So this medical education, first of all, help me think through this, right? It makes sense that professionals of a certain field who are most knowledgeable about that field should have a say in how that field is regulated, right? So here it's the Medical Council of India, comprising of doctors, sort of regulating their own profession and how it's educated. But if you are incumbent doctors who have jobs and you get to decide, you get to be the gatekeeper for new doctors coming in, that's a massive conflict of interest from the get-go, right?
True. All this, you have rightly pointed out this issue, and in order to solve this issue, the Medical Council of India had to go.
Right.
It had to go. So one of the first things that the Modi government did when it came to power in 2014 was to appoint the Ranjit Roy committee, which recommended several drastic changes to be made in the medical education regulator in the country.
Right.
And that ultimately gave rise to what we see now as the National Medical Commission Bill.
Right.
So the NMC Bill aims to solve many of these issues that medical education in the country faces. It has done a good job in trying to completely overhaul the system. The point that you raised right now, there will be some presence of non-medical persons in the board, in the 25-member board of NMC, though they will be nominated. But then this really paves some, way to reduce that conflict of interest that you were talking about.
Right. So finally, that problem has been acknowledged and is being addressed, right?
Yes.
And I think even before the Modi government, there were some attempts, I think around 2011-12 also to change how medical education is regulated and so on. But from the beginning, this idea that all other education is regulated one way and medical education alone is regulated through this parallel system seemed a little bizarre, right? So medical is almost closer to how, say, CAs work and certain other rare professions work, right? Maybe law and the Bar Association and so on, there might be a parallel.
Indeed. I guess many of these higher education bodies act or function like silos, and the guarding of turf that happens at that level is fierce,
right?
To put it mildly. So yes, and you see the Indian Medical Association, the body which represents all the doctors. If you look at the and they are having a strike which is going on since a few days now over the NMC Bill, and we'll come to that issue in a while. You see, IMA stands for things which is suited to them, whereas neglecting many important things like patient safety, quality, etc. So yes, we need more democratization of any higher education regulator in the country. Medical education is no different.
Right. And in a sense, any form of self-regulation in India has seen its limits, right? I mean, media is supposed to have a self-regulator.
Absolutely.
Yeah, they don't really police themselves. Doctors are supposed to police themselves in one way or the other and maintain quality.
We are all cut from the same cloth. So
we're all cut from the same cloth. Unfortunately, at least when it comes to things like media, the answer is never government, right? So media doesn't police itself, so Sarkar will. That doesn't work. But here, to me, bureaucrats, at least, or bureaucrat-appointed people who are regulating medical education still seems to me like a step better than, sort of elected and selected doctors in a purely doctor-oriented body.
Indeed, Pavan. Like we will have 3 non-medical persons in the board now, which is a welcome change.
Right.
Though the acquisition also at the same hand is that since they will be nominated by the government and they will be bureaucrats, government will have a say in most of the things.
Right.
So
and especially the government of India.
Exactly.
Okay. So let's come to the NMC bill in full detail in a bit. Can you give us a sense of the kind of numbers we have right now with doctors?
Yes, I guess
before we recorded this, both of us tried to dig up some numbers and we found all kinds of numbers, right?
Exactly, Pavan. Numbers, I mean, I guess that's the story of most things in India. The numbers are both unavailable and unreliable.
Right.
But yeah, the doctor's number make for an interesting story because it is this premise on which a lot of things are built.
Right.
So let us start with the requirement part, the number requirement. So I guess we all now are very familiar with this fact that WHO mandates a doctor-patient ratio of 1:1,000.
And this is a low benchmark.
This is a low benchmark. And most of the SDGs also are fixed at this number. So with 1:1,000, now we have reports telling us that in India this ratio is 1:1,674 from one source. And you were mentioning some time back it was 1:2,000 you read somewhere. The NHM report, which when JP Nadda was the health minister and it was released a couple of years back, the NHM report made a startling statement of this ratio being 1:about 11,000 for the country.
Okay.
So we have
less than 10%. So we have estimates between sort of 10% to 60% of the bare minimum requirement suggested by WHO.
Absolutely. And very recently, okay, now there is for the listeners, there's a stock and flow issue here. For the uninitiated, stock is the number of doctors that we have in the country
for practicing,
and flow is the number of MBBS graduates that pass each year and get into the system. Right. So let me first finish about the flow part because those numbers are solid.
Right.
Because you know the number of medical colleges, you know the number of seats, that calculation is easy. So last heard, we have 536 medical colleges in the country.
Okay.
260 of them are in the private sector, 276 of them are in the government sector.
Okay.
These 536 medical colleges have 79,627 seats with them.
Okay.
Of which 48.5% of seats are in the private sector.
Okay. Almost half and half.
Yes, almost half and half. So the flow numbers are clear.
Right.
About the stock number, it's a bit tricky. Once someone registers with the State Medical Council and is up and ready for practice, no one knows what happens next. Because there is no provision for re-registration as it happens in many other countries.
Right.
So once they have registered, then they say people who do not practice, change professions, people who go abroad, we don't know those numbers.
So even if you have a driving license, you're supposed to renew it, even if it takes 25 years or something. But a medical practitioner does not need to renew anything. Yeah. Once they are recognized as a doctor, they can practice.
Yes, we did have this issue in Karnataka of re-registration where, recently people did that, but these are all isolated instances.
Right.
And it's not a nationwide phenomenon.
Right.
About this problem of how many doctors are we lacking? Again, various people suggest various numbers, but then if we are to take at face value the number given by Amitabh Kant from Niti Aayog, he tweeted just couple of days back that we are short by 6 lakh doctors and 20 lakh nurses in the country.
And we don't know what the full size is, but this was the number quoted.
Yes.
And so we have anywhere between, 6 to 10 lakh doctors perhaps working in the country right now.
Correct.
And we need at least the same number again, right? And so that means that if you want to, say, double the stock, you need to increase the flow 5x or 6x or something to be able to get there in a reasonable amount of time, right?
Yes, Pavan, very rightly pointed out. Government is trying to increase the number of seats, but then it's not as easy. But also to mention this small point about the number, we also have this serious problem of distribution. So when we say that the ratio is bad, you will actually see that in cities, in metropolitan cities, you will have this ratio being very good.
Right.
In Delhi, the ratio might go up to say 10 per 1,000.
Right.
So we have a distribution problem equally. And we know that many of the PHCs and CHCs are having severe shortage of doctors.
Right.
So this adds to the problem of numbers. So we can't see numbers in an isolated manner. Right. We also have to see the distribution aspect of them.
Which is why the quality of healthcare, say, that you and I can access today is pretty much the same as that of a first world country. Indeed. In fact, perhaps far more affordable.
Exactly.
And but that's not the case for 95% of all Indians, right?
True.
So this is one thing. But tell me also, how expensive is medical education today? I mean, clearly the supply is highly constrained, which means that if supply goes down, then price goes up because the demand will always be there.
So with National Eligibility Cum Entrance Test NEET becoming an all India exam and the government banning all management quota seats.
Right.
So ultimately what happened is, since the last 3-4 years time, the average fee for MBBS rose up.
Okay.
So if I am to cite an example, if colleges were charging a decent private medical college, if was charging say 6 to 7 lakhs per year, they began charging in the range of 14 to 17 lakhs per year.
Wow. Okay.
It shot up. I guess that calculation is simple. The money that the management quota seats used to garner was kind of divided among all the people coming in.
Right.
So medical education is very expensive in the country. The new NMC Bill does provide a 50% relaxation to private medical colleges, in the sense they can fix fees for 50% of medical seats.
Okay.
To put this in number, we have about 38,000 seats in private medical colleges in India. So about 19,000 seats now, the fee for those 19,000 seats can be fixed by the private medical college.
The rest will be determined by
the government. I guess I want to make a very important point now is that we should not see higher education as such and medical education in particular to be a charity. It is expensive.
Right.
And since we have associated profit making in higher education, of course, this has come down even from Supreme Court that profit making should not be the motive of higher education. I guess that's a very flawed premise on which all these things are working. So
then it becomes a game of, okay, so we'll make it as a non-profit trust, and then you hire a management company to come and do managing services, and that's private limited. You just create unnecessary sort of loopholes and things, right? Because again, I mean, if people want to spend their resources in it, they want some kind of a return.
Absolutely. Medical education is expensive. So one thing is capacity building by government, which is an excruciatingly slow process.
What does that mean? I mean, build capacity in government, you mean?
No, I mean by establishing medical colleges.
Right.
Which has been very slow.
Yeah, I mean, that was the other development of the last decade, right? And aims in pretty much every state. That doesn't happen overnight.
And even if it happens, do you know what the vacancy rate in aims is? Up to 60%.
Wow.
Yes. All these new aims which has come up, they have a vacancy rate of up to 60%. I mean, there's no point just opening, mushrooming IITs and aims all over the country.
Right.
So yeah, coming to the expense part, yes, medical education has become very expensive.
And because it is so constrained, and I've heard stories of medical colleges in and around Bangalore and other places. You know, when you go for admission from the management seats or whatever, you have rooms with sort of cash counting machines because, you know, people are giving these donations, I guess. Yeah, because you're a non-profit entity, you have to give a donation of, I don't know, 25 lakhs, 30 lakhs in cash, right? So you're fueling a black market economy and you're doing fairly nasty things in the name of, regulating medical education.
Right, Pavan. These management quota seats had become infamous for all these things. But I must admit that some capping in that area has been done.
Right.
With the demands of having counseling, recorded counseling and face recognition, etc. Use of technology has indeed helped to a great degree in, countering these fake admissions.
Right.
So we have come quite a long way in that.
So all this gives us a sense of how expensive it is today. So anyone who actually invests that amount of money wants to make a return from it, right? Any private individual, any student. And what's the value of that degree now? I mean, I think the job that you get when you have just an MBBS degree will fetch you 20,000 rupees a month, 30,000 at best.
Yeah.
If you're like a duty doctor in a private hospital. And with no career progression path at all, right? True. So why has that happened? I mean, why is an MBBS degree seen so poorly and in such poor light? You need a PG, you need an MD to, have a name board and open up any kind of service.
Couple of things. I guess first is that the average competency of a MBBS doctor over the years have fallen to such an extent that if you and I were to have an option of going to MBBS doctor or a specialist, we'll definitely choose a specialist, even if that demanded us, say, taking some hardship.
Right. I must tell you, I've been extremely fortunate because I have a general physician who's a family member, so like an uncle, and I'll tell you that my personal quality of healthcare is superior to so many others because I have this GP who has known me for decades now and understands when I go to him with a problem. And ideally, that's the whole idea of a family doctor, right? 30 years ago, many of us in the middle class had a family doctor of some sort. Not everyone had access to them, but at least that was an easy, inexpensive solution to a lot of problems. You have a throat infection, you need someone to write you a prescription and just ensure that, you have a bacterial infection. That's it.
True. This movement towards specialization, which has happened in all these years,
right?
There is no turning back from that now.
Okay.
We are in a specialized and super specialized era.
Okay.
Where the greater number of degrees and if obtained from abroad is better. And of course, only if you can afford it.
Like, why is it the thing now? Because it has that much signaling power that the quality of whatever medical advice that you get will be that much better?
Indeed.
Okay.
I'm not sure, but there are multiple reasons. One is that everybody wants the best care. So a specialist is seen as someone who can solve your problem in one go.
Right.
You wouldn't want to first go to a GP who will then forward it to somewhere else. Also, with the greater corporatization of hospitals, the notion that the productivity of these doctors increases, who allots you just say 2 minutes after you have gone through a series of people.
Right. Somebody takes your weight and your BP and something else. Somebody else writes case notes on a page. And then this senior doctor just spends 2 minutes, right?
Right. And all this compounded with the fact that the average quality of a simple MBBS graduate is slightly dubious. People wouldn't really want to go through that process if you have the means to do it.
Right. And it's not like as a new MBBS doctor, if you just set up your own clinic, very difficult to attract patients and be trusted, right? Because if you're talking about family doctor and so on, you need trust. You typically need someone who looks old, who looks wise, who's seen a lot of patients, lots of things like that.
Indeed. There's, as you were rightly mentioning, there's no career progression for that MBBS doctor. So there is only one way that fellow has to look towards to, and that is securing a postgraduate seat, and which is in short supply.
And that's much smaller, right? I mean, you were talking about 79,000 or something MBBS seats.
So roughly half, about 40,000 seats.
Wow. Okay. And that's spread across surgery, everything.
Absolutely.
And then if we finally come to a question like, why don't we have enough mental health professionals in India? We don't have any medical professionals in India.
Oh, yeah.
Why would they go to mental health?
Exactly. The psychiatry specialization ratio is terrible.
Okay.
Is beyond bad.
So you have, in a way, short supply of many specialities as well.
Yes.
And of course, surgery and a few other things, you will find people.
Indeed.
Unfortunately, often at the right price point only, right? Or in the government system. So this is the state of affairs. Anything you can tell us about any efforts for working doctors that are currently there? Is there any retraining classes that are done anywhere? Anything that you have come across?
There are increasingly more number of continuing medical education workshops and all are being conducted for doctors, but then they are not a structured program as such.
Right.
So it is for that individual to find out what is happening in their own field. Although some credit hours are being given, and this is a good change that has happened in recent time, that doctors have to earn certain number of credit hours through attending conferences, CMEs. So putting the effectiveness of those things aside, there is now a mechanism built where people are encouraged to, or they're even mandated to some extent to attend these, continuing medical education programs.
Okay. So there's at least something
yes.
which can hopefully be strengthened as well.
Definitely.
And the final thing I want to touch upon before we take a break and dive into this NMC entirely is that one of the challenges today people have complained about brain drain in medical education for a very long time, right? Oh, the best doctors, they get subsidized medical education from the government, and first thing they do, they write the USMLE, go to the US or go to UK or somewhere else. And there have been quite a few moves in the last 2 decades where compulsory rural postings and all kinds of things have been done, right? So can you give us like a sense of how the government has looked at this problem? And how would you look at this problem?
Well, when people did not go voluntarily to such rural settings, the government and many state governments, because again healthcare is a state subject,
right?
So many of the governments tried doing a very interesting thing. They mandated certain years of rural posting, the benefits of which would go towards them obtaining a PG seat, a postgraduate seat.
Okay.
Because now we have seen that, we have seen that this postgraduate seat is a thing which is in short supply and in demand. So, and is a must go if you want to progress in that career. So, they linked these two. And it has been working in some way or the other. Young MBBS students are going to rural postings.
Okay.
As far as people going abroad, we don't have much evidence of reverse brain drain happening.
Really?
Yeah,
I mean, most doctors we see in India seem to have some letters. Some I've seen FLSR, whatever.
FRCP and
from abroad, right?
I mean, they did go there. They have studied. They have done specialization there and have come back.
Right.
But then people who are established abroad are established. Apparently, there are about 1 lakh Indian doctors in the United Kingdom alone.
Wow.
So it is said that the NHS will collapse if these people were to, come back.
1 lakh doctors is like more than 10% of all doctors in India.
Yeah.
Amazing.
So if they are to be sent because of some Brexit issue or something. But many healthcare systems are surviving on Indian doctors.
Right. So in that sense, if we solve sort of our Indian problem of a doctor shortage, we will actually be solving a part of a global problem as well, right? Because you increase the number will go everywhere, and
True.
a greater number will also stay in the country if
True,
opportunities increase and improve. So that's one thing, right? There are actually many issues in which if India solves its problems, I think it is solving a lot of problems. So that's a slightly positive note for us to take a break on before we come back and see what this new, NMC bill is all about and whether it can, help us bring about that transformation that we also, at least we have intellectually acknowledged that this is what we need and this is a problem that we need to solve. Thank you so much.
Did you know that Parsis in Mumbai, instead of being left at the Tower of Silence after they die, are now cremated? And why? Because a cow fell sick in the early 1990s. Did you know that the smog in Delhi is caused by something that farmers in Punjab do and that there's no way to stop them? Did you know that there wasn't one gas tragedy in Bhopal, but 3? One of them was seen, but 2 were unseen. Did you know that many well-intentioned government policies hurt the people they're supposed to help? Why was demonetization a bad idea? How should GST have been implemented? Why are all our politicians so corrupt when not all of them are bad people? I'm Amit Verma, and in my weekly podcast, The Seen and the Unseen, I take a shot at answering all these questions and many more. I aim to go beyond the seen and show you the unseen effects of public policy and private action. I speak to experts on economics, political philosophy, cognitive neuroscience, and constitutional law so that their insights can blow not only my mind, but also yours. The Seen and the Unseen releases every Monday. So do check out the archives and follow the show at seenunseen.in. You can also subscribe to The Seen and the Unseen on whatever podcast app you happen to prefer.
Hi, I'm Pavan Srinath and welcome back to the Pragati Podcast. I'm here with Sambit Dash and we are talking about medical education in India. So Sambit, we've sort of laid out the various problems around medical education and the medical profession right now. What does the NMC seek to do?
All right. The National Medical Commission Bill, which was introduced in the Lok Sabha on July 22nd this year,
This was reintroduced, right?
Reintroduced.
First introduced in 2017 or so.
Yeah, it lapsed with the suspension of Lok Sabha, and it was reintroduced. So the bill aims to fix certain things in medical education, like availability of adequate and high quality medical professionals.
Mm-hmm.
It aims to adopt the latest medical research by professionals. It also will do one of its core functions of assessment of medical institutions.
Right.
And to establish a grievance redressal mechanism.
Okay.
So this NMC bill, in a complete departure from the earlier MCI, will have 4 autonomous bodies under it. And they are the Undergraduate Medical Education Board, the Postgraduate Medical Education Board. There will be a Medical Assessment and Rating Board. And finally, there will be an Ethics and Medical Registration Board.
Okay.
Which will be a national register.
Right.
So perhaps solving the number issue as we go along.
But even when things are registered, like with EPFO data and so on, it's very hard to finally find out the numbers in the country. But fair enough. So is this different? So right now, MCI as a body is doing all of those functions?
Yes, MCI as a body alone was doing everything.
Okay.
And it was suggested in the Ranjit Roy committee to diversify the functions and distribute it to other bodies.
So this is like the equivalent of, we have UGC for universities, we have, I think, AICTE for the technical education.
Yeah.
So you have multiple boards and they're nominally independent.
Yes.
All right.
So the NMC bill has now been passed both in Lok Sabha, Rajya Sabha, and is perhaps waiting for a assent by the president and released as a gazette.
Right.
So this is where we stand with the NMC bill.
And even now, this sort of comes under the health ministry?
Yes.
Okay. So health ministry retains medical education in this place.
Yes.
And constitutionally, where does medical education sit?
Medical education is in the concurrent list.
Okay. So while health is a state subject.
While healthcare is a state subject.
Okay.
Medical education is in concurrent list. And that makes it a little tricky. Once we come to the issue of this community health workers, which has raised much furor in the country right now and for which the IMA members are protesting, we will see how this incongruence of healthcare being state subject and education being concurrent in the concurrent list, we'll see how it has played out.
Okay.
So let me come to this issue which has become a huge bone of contention in NMC bill, of that of the community health provider.
Okay.
So I'll take you to the previous version of the bill where it was mentioned that the Ayush professionals can practice modern medicine after a bridge course of 6 months.
Okay.
It was in the previous version. But then again, it was met with a lot of resistance, and rightly so. And in this new version of NMC bill, the cabinet had actually at that point of time also struck off that provision. And in the new NMC bill, we have this community health provider, a provision for community health provider through Article 30, Section 32 of this bill, wherein it is stated that the allied health professionals can, after a suitable course, practice modern medicine.
Okay. So they don't get to call themselves doctors, but
that part is still unclear. There is absolutely no clarity over this issue. But then India has had some history of this community health provider, and or which we can technically call as the mid-level practitioner.
Right.
Mid-level practitioner is an important cog in the wheel of healthcare system.
Right. And even right now, say the National Health Mission has MLMs in their list of people they work with, right? In their positions and so on. Indeed.
But they do not have the rights to prescribe, say, allopathic medicine.
Fair enough.
So this departure from that kind of health provider to this mid-level practitioner, or which is called as community health provider, let us slightly look into this issue. So we all acknowledge that there is gross deficiency of doctors in PHCs all over India.
Right.
The PHCs are all targeted to be converted to what is called as your health and wellness centers. The 150,000 health and wellness centers which has been envisaged by this government.
This is as a part of Ayushman Bharat.
Exactly. This is part of the Ayushman Bharat scheme. So, who is going to provide that care, that mid-level practitioner? Who is going to provide that? So that is an important question. Before I come to the answer of this question, I'll go to the short history of this community health provider or mid-level practitioner. When Chhattisgarh was newly formed, it had only one medical college with 100 seats.
Okay.
Most of its health centers were in the rural areas.
Right.
Almost 2/3 of them. There was gross deficiency of doctors there. So what they did is, under the Chhattisgarh Chikitsa Mandal Act of 2001, they started a 3 years rural MBBS program.
Okay.
Yes.
And they called it an MBBS program.
Yeah, it was called MBBS programs, and RMAs were to come out of this system in 3 years' time. The system did churn out some 1,400 odd professionals.
Okay.
Who went to these rural centers, and very interestingly, and we have studies for that, did quite well. In some of the empirical evidence that we have, the diagnosis of these RMAs were compared with the MBBS doctors, and these people were almost at the same level or marginally even better.
Okay.
Very interesting. But then, of course, the Indian Medical Association chapter of Bilaspur, in an effort to guard its turf, filed a case in the High Court. That case is still going on. But what happened in the meantime was a lot of change in nomenclature happened. The medicine, surgery names were dropped from these, courses, and ultimately they were rebranded as just healthcare professionals and sent.
Okay.
We have a similar story in Assam also, where in 2005, under the Assam Rural Health Regulatory Authority Act, what they did is they again had a similar kind of course. Again, the state IMA chapter filed a case in the High Court, and High Court considered this as unconstitutional. Again, because of the issue that we were talking about, that medical education lies in the concurrent list, and thus state governments cannot themselves design a curriculum without approval from the then MCI. So this is one part. After the bridge course idea was mooted, many states and notably Maharashtra started this bridge course and have even churned out 2 odd batches of mid-level practitioners who are to practice in rural settings. So you see, Pavan, let us first and foremost acknowledge the fact that to have a cadre of mid-level practitioners can be a game changer for the dire healthcare situation in the country.
Right. No, and honestly, if anyone's ever been admitted to a hospital, most of the actual care being provided to you is provided by nurses and senior nurses, right? They're not provided by doctors. Doctors will write the prescription, they will diagnose you, and they'll give high-level orders. But people who are doing all the routine work are qualified nurses. So in that sense, there is one of the challenges I see with sort of the Indian medical landscape is almost sort of the near Brahminical role played by doctors, right? They're the apex profession in this entire system, and they get to call all the shots. I mean, is there, say, a head of the nursing department in AIIMS who is a member of, say, MCI or something else?
Yeah, exactly.
Right? We don't see that kind of participation by anyone else.
Correct. But here what we are, talking about the community health provider and the issue that making them practice modern medicine, which is basically limiting them to prescribe medicines, allopathic medicine, is to legitimize quackery. I don't think that argument holds.
So I think that argument came, and I think I've made perhaps the same argument when people said 6 months bridge course for Ayush workers and then they can prescribe medicine, right?
That is untenable. Frankly, that is untenable.
Right. I mean, so anyone who's actually genuinely been brought up on Ayurvedic or homeopathic modes of treating, and then you tell them, okay, now you give people crocin or antibiotics. It's just absurd, right?
Yes, Pavan. I want to make few points about this. Number one good thing that NMC Bill has provided is that it has, changed Ayush to allied healthcare. So you see...
That's a great term.
Indeed. In my opinion, if, say, a physiotherapist wants to undergo this bridge course, which will be my second point when I come to it,
right.
want to do a bridge course and practice limited modern medicine.
Right.
I'll come to limited in my third point. Then so be it.
Right.
Coming to the second point of course. Yes, the 6 months that was earlier envisaged was absolutely callous and untenable. It can as well be a 1.5 year course or whatever. That has to be designed by education experts, and it cannot be a randomly thought about time frame to be completed.
Right.
Third point that I wanted to come about is limited medicine. And this is a very important point I feel about this aspect. Okay, the NMC Bill doesn't ask these community health provider to practice full-fledged modern medicine. No. But their role is to be clarified. That role clarification has to be there. That they can prescribe this, they can do this, say, for example, a simple suture. Or something of that sort. That role clarification is important. Let us at this point also acknowledge the fact that quackery is very prevalent in India.
Right.
There are studies which have established that your chance of visiting someone who is just a 10th pass and is practicing medicine in UP is very high.
Right.
So we are in such a milieu.
So basically this undersupply of trained, recognized professionals means that the demand is being met by whoever who claims to wear a white coat and claim that they are a doctor.
Exactly. Funnily, we have seen those videos where, the roadside dentists in Varanasi who will, treat all kind of... that is again because of...
right.
Anyway, that's a separate debate. But yeah, coming back to this. So, in a setting where quackery is so prevalent, isn't it really a good idea to develop this mid-level professional or the community health provider who serves as an important link between people who are, who are in dire need of medical access to medicine, and the, say, the MBBS or the specialists. Right. So this mid-level practitioner can, if the role is clarified, the right course is identified for that person, can really identify the problem, prescribe basic medicines, follow up, and can also identify situations which he or she cannot handle and refer it to the right authority.
Right.
I mean, that would be really what Indian healthcare needs.
Right. And what we were talking about, the flow increasing by 5x and 6x, it might only be possible for us to achieve it by increasing the number of MBBS seats and these allied seats, right? And it also, I mean, in a sense, this is also a problem with our technical education, right? So you have engineering, but you don't have sort of trade practices, somebody learning how to do smithing well, other things well, and that vocational training is the separate track, formal education is a separate track, and someone who's gone down one route cannot shift to the other route. And even here is someone who's become a really good physical therapist can look to progress in their career later on because of a bridge course like this.
Pavan, this shifting route point which you said is very, very relevant. The whole medical education sector functions in such silos
Right.
In such a silo that the entry barriers are very high.
Silos and ceilings, right?
Yes,
if you're
absolutely.
a nurse, there is only so much you can go up to. But if you're a doctor, you can become the head of a hospital or whatever else.
Absolutely. That really brings me to the next major point I want to make about this community health provider or this ceiling and silo that we are talking about. That we have umpteen number of examples abroad where there is a system of what is called as a physician assistant.
Right. Or I think there's also the term nurse practitioner that some people use. Right?
So these physician assistants are, say, people from these very allied health services,
right,
who would take up a course of few years and become a physician assistant. Why can't we really, for the job crisis that we have in India, this strong cadre of the ladder that we are talking about, say mid-level practitioner, we have a physician assistant, then you have doctors. I guess that is where we should be looking at.
But the kind of political economy that sometimes prevents this, right? I think there's an example from North Carolina or some other state in the US, if I'm not mistaken. I think in their system you can have full-fledged dentists, but you also have dental hygienists, right? Whose main job is, say, cleaning teeth and so on. Now, I think people realize that there were some things, like the most cosmetic of cleanings, where you don't even need the dental hygienist tag. And it's now an off-the-counter thing that anyone can do. So there are these shops that people have set up in malls where they'll clean your teeth in like 5 minutes. And it's an unlicensed profession, but people are happy with the service they're getting. But the people who are the incumbents who have the licenses are now fighting to get all that banned and regulated and so on, right? So there is this... Typically, we look at regulation as, government putting controls on things, but often regulations for keeping competition out.
Indeed.
Right.
And Pavan, I guess this would demand a separate podcast, the situation of dental education in India, where we are now facing a problem of huge supply.
Okay.
Yes.
Too many dentists.
Wow.
Okay.
Colleges shutting down, seats going vacant since last 2-3 years. And so probably that's a...
So while doctors are not around, you have too many dentists in India.
Yeah, and through these bridge programs, I feel we can really have some dentists who do study all those subjects for all those years, who would want to make a shift. Why can't we really provide them an opportunity to make a shift?
Right. So the person we should not be thinking of is... not a homeopathic doctor or an Ayurvedic doctor who wants to shift in 6 months, but professionals working in all these other fields after spending, a year or two learning something proper, being given a chance.
Indeed.
Okay. So that's a fundamentally different way of looking at it. But this is something that the current doctors are not very happy about. The IMA is not very happy.
Definitely not.
Definitely not. Okay. So I think let's see how those protests play out. But if I'm not mistaken, another contentious issue of this is an exam to become a doctor, right? In India, we are very, very comfortable and we have taken it for granted that you need an entrance exam to get into any good college. That is a given, right? All of us write umpteen number of exams to get anywhere. But what is this business of this national exam, like a board exam for doctors when they're about to graduate?
Right. So the second very important contentious issue in NMC Bill is this exit exam, which is called as NEXT.
Right.
National Exit Examination. So this little bit about NEXT. Pavan, like you mentioned, the entry issue is kind of sorted.
Right. For better or worse.
Yeah. Though there are many issues there, and I personally believe there should be more levels of entry, not just one. But that's a different issue. So now we have NEET as a single entrance examination to choose students who are qualified to study MBBS. That part is clear. The quality of MBBS which passes out has been a concern since very long time. Mudaliar Committee of 1959 since then have stated that the quality of MBBS which passes out is poor. We need to do something to curb that. And this thought of having a licensure exam at the end of MBBS to maintain that minimum standard of quality has been mooted since some time. So when this NMC Bill first came into the realms of consideration, this next came surfaced as a NLE, National Licensure Examination.
Okay.
And it was supposed to be a separate exam
Right.
at the end of MBBS, which will give you a license and will qualify that you have this minimum standard of competency.
So it's only needed to practice. So if you wanted to do your MBBS and then do something else, you didn't care about that exam right then.
Yeah.
Okay.
But then what happened is that there was huge protest for having another exam after the end of final year MBBS exam, and then cabinet dropped that plan.
Okay.
What they did was they told that, okay, now we'll not have a separate exam. The final year MBBS exam will now serve as your exit exam.
Okay.
So if you pass that, you're good enough to practice, or you'll get a license to practice.
Now,
there are...
hang on, just a clarification. So right now, if you're in a medical university, your final year exam is set by your university, right? So,
Yes.
But they're saying your final exam will be like a board exam.
Yes. Now let me try to clarify this point. So now, at present, the final year exam in MBBS comprises of 4 broad subjects: medicine, surgery, OBG, and pediatrics.
Okay.
Smaller subjects are incorporated into that, but then there are these 4 subjects, and you have a theory exam for these and practical exam for these.
Okay.
So this is what the final year examination is, and as you pointed out, every university has their own exam. Of course, they are all guided by the whatever provision is there in the MCI.
Right.
But that is what.
And if it's a medical college, then say the likes of the Rajiv Gandhi University, which takes care of all of Karnataka. That's
Exactly.
Okay.
Exactly. All right. So now, what happens? There is a theory exam. There is a practical exam. Students write. Result is published. You get 50% of marks. You pass.
Right.
That is what is happening now. So, major questions that arise at this point is, if you want this exam to be your exit exam, how are things going to be different than before?
Right.
Number one. And this is all because there is no clarity whatsoever in the bill about how they want to do it. Second, if you really want this final year exam to be your exit exam, will you have a standardized exit final year exam throughout the country? I don't think that it is possible or feasible.
Okay.
There will always be subjectivity depending on university to university, college to college. When you have a practical component which has so many variables, how can that be a uniform one?
Sure.
Now the whole problem gets compounded when the NMC Bill has provided that this very exit exam, which is now the final year MBBS exam, it will be your entrance exam for the much hallowed postgraduate seats.
Wow. One exam to rule them all.
One exam to rule them all.
Incredible. So, and that's so bizarre, right? I mean, because people in India take entrance exams many times over. How does this work?
Very good point, Pavan. This is another major issue for which the strikes are on, that if someone wants to take the exam again, what will that person do for, say, one whole year? And how will he or she take it? And with whom? Will he or she take it with the next batch? And if there's a large number, then how will that logistics work?
Right.
And if, for example, of a particular college, say college X, since the PG seats are very low, say only 10 people out of 250 people get through PG seats. So will that college be now considered, because ultimately that PG seat is now that ultimate goal.
Right.
So will the reputation and ranking of that college be down?
So now instead of just an entrance exam determining the rankings of colleges, the exit exam will start determining it also.
Unofficially it will.
Right.
Because that is where the stakes are.
Right.
And Pavan, this point about one exam to rule them all, there is another purpose of this exit exam now.
Okay.
Which is, until now, there was a foreign medical graduate entrance exam, which is for those MBBS students who have passed their MBBS abroad and want to practice in India. They were writing a foreign medical graduate entrance exam, and then they were able to practice in India.
So this is the equivalent of the US MLE that Indian medical graduates write when they want to practice in the US.
Yes.
Okay.
Now, this very exit exam, which is going to be the entrance for the PG, is also going to be the foreign medical graduate entrance exam. So
foreign grad should come, somehow hook up with a college in India and write exam there.
Yeah. Where will that fellow go to?
And what's the incentive for any college to take that person?
To take that person. It's absolutely baffling what is going to happen. Now, but
in theory, right? So, I know that you and Anantman, I think, published a paper on this in EPW as well, right? But to me, the principle of an exam, not having it as a final exam, but the principle of an exam is a good idea, right? Or at least it's an idea that has parallels. You have a bar exam in law, you have to write a CA exam to become a CA. So that part sort of makes sense. That, if there has to be a gate put, especially with a profession like the medical one where lives are at stake, a software engineer at the worst case writes bad code, right? I mean, lives are usually not at stake. They should probably be in civil engineering and other things. But in principle, that makes sense to me. So how have you and Anant looked at this? How do other people see this exam?
Pavan, I will slightly get into the fundamentals of an examination before answering this part. But before that, what you said is absolutely correct, that we need to have a test that determines the quality of the MBBS graduate coming into the healthcare system of country. Right. This also finds, great acceptance in the society. I mean, we are all, I guess, on same page on this aspect.
Indians love tests.
Yes.
Indians love working towards tests. Okay, so all that works.
So coming to an exam, a test is as good as its intended objective.
Right.
In an exit exam, where you want to check for the quality of that MBBS graduate, you want to test three things. You want to test the knowledge, the skills, and the attitude.
Right.
Which in education parlance we call as the cognitive domain, the psychomotor domain, and the affective domain.
Okay.
You want to check for these three things. Right now, the final year examination, MBBS examination, does check for the first two.
Okay. Knowledge and ability.
Knowledge and skills because of the practical component. Affective domain, sadly, the Indian higher education doesn't give much importance to the heart.
Right.
Head and hand is good enough for us.
Right. And you don't even train people on that, so why test them? Right?
Exactly. Some improvement in medical education has happened over the past few years when this CBME in medical education has been introduced, and there's something called
CBME. Sorry, is it continuous evaluation or education? Or
something? There will be more of formative assessment in this.
Okay.
Small group teaching. They have a ATCOM module now for MBBS students where they will be learning communication and soft skills in the beginning.
Right.
Welcome changes. Though I have my doubts about how the huge staff requirement that will go up when you have small group teaching.
Right.
I have my own misgivings. That's a different thing.
And I have my misgivings about any ethics courses and classes. Usually they turn out to be the most boring one, taught by the worst people, and you feel less ethical at the end of a course than more. At least that's my experience from engineering. So I don't know. And it's more important in medicine. So I don't know.
Very much. But yeah, it's a very good move that in recent years, some change in curriculum has been asked for.
All right.
Okay. Coming back to our exam fundamentals. So an exit exam needs that. An entrance exam And especially in an Indian setting where for this particular PG seat where number is less, entrants are many. So an entrance exam is just to qualify
Right.
or choose people who are eligible to enter that. And thus making this final year MBBS exam as your entrance exam and also as your licensure exam are at odds with each other.
Right. And an entrance exam, at least currently, only tests knowledge, right? Not
Yes.
even skills.
Not even skills.
Because there's no practical component at all.
Exactly.
And it can't be done at scale.
Can't be done at scale. But, and this is what one suggestion we mentioned in our EPW paper is that there is a mechanism to do that. Okay, let me give you a wild scenario of how it can happen. Say, and there are examples. Before coming to that, let me give you a slight, thing about the situation abroad. So the USMLE has been going on since 1992.
Okay.
And most licensure exams abroad are in steps. They are not just one test.
Right.
So, like USMLE has 3 steps in them.
And in the middle, you're supposed to get work experience
Exactly.
in the US.
Residency,
lots of
and
things.
a lot of things. In Canada, we have such a system. The UK example is very nice because they gave a long period for its implementation. So the idea started about 2005, then the design came in 2015, and they have until 2021 to start implementing it.
Okay.
We have a paper from South Korea which says how this how skills can be tested also at a large scale.
Okay.
So let's envisage a situation where you want to have a uniform test sort of thing. So, say example, we have 80,000 odd graduates. Of course, this thing will take time. Capacity building has to be done. Say government identifies 100 colleges, 100 top colleges distributed uniformly in the geography out of the 500 odd that we have, 536 odd that we have. And these become center of excellence, sort of.
Or they just can't become exam centers.
Exam centers, right. Exam centers. And then there can be your objective structured clinical examination or skis to test for the skills, because skill testing becomes very tricky.
Right.
So, not that it can't be done. I guess there are much, the positive externalities are high for the government to really invest in this, and technology can also be used. There are mannequins, simulation labs. These can be set up and skills can be tested. Because knowledge testing is perhaps a low-lying fruit, low-hanging fruit. You can always conduct a MCQ and test for it.
Right.
So, yes, we need to isolate this, the exit exam has to be seen in that light. One is we have to test for a basic standard competency of the MBBS graduate, which should involve your skills testing and attitude testing. Once that is done, those who qualify, perhaps then the test for postgraduate, which has to be uniform.
Right.
Uniformity is of great importance there when you're choosing from lakhs of people. So perhaps that can be the next step.
Okay. So have like a phased exam.
Yes. So I think
where the idea is you clear one phase and now you can practice, you clear a next phase and then you're eligible
for the postgraduates. Absolutely.
Okay.
And even the foreign graduate thing also will fit in here.
Right.
And I want to spend little time on that aspect. It is really good that the foreign graduates can come and address the gap that we have, the number gap that we have. But then again, we also want to check for their competency, right? So if we have a system where we are, say, like we were talking about the exam center, that becomes much easier for those thousands of students to come and, join exam center.
And those centers can also be adequately compensated by the government for the conduct of these exams and so on.
Exactly. Otherwise, it goes back to our old problem. Which university will that fellow go to?
Right.
It's a very tricky situation.
So, The other thing I see in terms of exams, right? The job of an entrance exam, and typically in India, I think the JEE now gets about 10 plus lakh students. Now they might be awarding, 30,000. There might be 30,000 seats across IITs now, or maybe smaller than that.
Around that.
So the job of the exam is to discriminate the top 5 to 10% from the rest. Right?
Yes.
So the difficulty of the exam, the nature of the exam is to ensure that the way the test is done, you have enough dispersal of scores at the top end.
Correct.
You don't really care about what's happening at the bottom end.
Correct.
Whereas with the medical college sort of exit examination or entry to the profession examination, my guess is that you will be passing half or more than half of the people who are taking it. I mean, if you're assuming that there are these 530 well-regulated colleges that are functioning, then maybe 80% pass or whatever, right?
Yeah.
And a smaller minority who might have to repeat things over a year or something. And that means that the objective is very different.
Exactly.
You're testing for minimums on various things.
Yes.
And whoever hops over the minimum is in. Right? So your nature of the questions you said, the difficulty, the distribution in the difficulty fundamentally changes.
Yes.
And you can't have one exam which does both.
Correct. And Pavan, this also brings us to another problem, that if this exit exam, in the current scheme of things, if this final year MBBS exam is to be your exit exam as well as your PG exam, what happens to the importance given to the subjects you have studied for the rest of the 3 years?
Right. Absolutely.
I'll just say one will just want to barely pass through those subjects, have a jolly good time and concentrate, because this is only exam that I want to concentrate on.
Whereas the entrance exams that exist try and look at knowledge that you've gained over all the 4 years.
They do. 300 MCQs currently, which covers all the subjects of MBBS.
So right now, the bill is just unclear?
Is very unclear.
They just say one exam.
3 years to implement from the time it becomes an act.
Okay.
So 3 years to implement.
So
this assuming that 3 years means 3 years from now the batch which joins. I mean, again, it's just our best guess.
Right. So that means there might be 7 years or something left.
Exactly. Any rule can be only implemented when the batch joins.
Right.
So, yes, frankly speaking, this is a very good opportunity for the Indian medical education system to transform things. You have with you they should call for national consultation on this. It has to be tested. It can't be just random. How things become difficult with, a pan-Indian exam.
Right.
There will again be issues of language coming in here, and
absolutely.
We have seen that happening with NEET. So there will be multiple issues now. So I guess it has to be taken slow. And I won't be really surprised if many things starts getting challenged in courts also.
Right.
Because again...
And that's the most bizarre thing to happen when... I think this happened with JEE exams at one point. Between RTI and the courts, the entrance examination conductors had to release scores, had to release other things, which till then they had kept private.
Right.
And it became like a right to appeal issue. Too many other things sort of come into that,
True.
right? So the idea of an exam is the line in the sand that you cross, and then if you attach extraordinary amount of importance to it,
exactly,
you also allow people to a lot of incentive to start gaming it.
Exactly. So that is what we were also mentioning in our paper, that right now this PG exam is very much gameable because it's just a MCQ based exam.
Right.
So we need to really think over that, because again, if you you make something gameable, it will only help coaching centers mushroom.
Right. And we already know that that's a multi-billion-dollar economy in the country already. And yeah, you don't want that to increase because of this.
So I'm very much concerned about this exit exam. The things that it wants to achieve, the multiple things it wants to achieve. I don't know. We have to go back to the drawing board with education experts, with exam experts, and think about the objective. Again, I go back to that fundamental tenet of a test is as good as its intended objective.
Right. And what you want is sort of a pass-fail test to enter the medical profession.
Yes.
And you want a selection of the best 10% for your PG exam.
Correct.
Right. So hopefully, so right now, because of the law, there is still a provision that it might become a 2-stage exam, right? I mean, there is nothing necessarily to stop that, given how the rules might go out.
I'm not sure. There is some internal inconsistency in the bill also about this, which was, I guess, pointed out by Manish Tiwari in his debate.
Okay.
There is some internal inconsistency regarding some of the sections. So
then it'll have to go to the courts.
I guess so.
Okay. So we're in for an interesting next few years. But I'm glad that we have finally started trying to fix the quantity and the quality issue of medical education.
Yes.
So what I think we can start seeing immediately is whether the rules for getting a medical college set up become more transparent and simple and straightforward.
Indeed.
And allows for better people to get into that ecosystem, right? Now,
yes,
it's, someone who has real estate or someone who has good political connections who often opens the next medical institute. And hopefully that can change too.
I'm not very hopeful about that part because it's a double-edged sword. On one hand, while the bill makes it easier to set up medical college, which is a good thing because then there were a lot of harassments happening in that area.
Right.
And also the bill provides for lesser number of inspections that are to happen. About 25-30 inspections used to happen for just setting up.
Okay.
So now the number will reduce. So yes, the entry barrier of setting up a medical school has come down, which will result in some medical schools opening up faster, perhaps. But the quality is to be checked by the exit exam ultimately.
Right.
So we have this situation where the bill tries to make it a free market situation where, the good ones survive in the end. But we have quite some time to see how it pans out.
Fair enough. Sambit, thank you so much for coming on the Pragati Podcast. It was an absolute pleasure to have you here.
Thank you, Pavan, for having me.
Thank you for staying with us till the end. If you have any questions or comments, do write in to podcast@thinkpragati.com. And hey, if you like the podcast and listen to us on iTunes or Apple Podcasts, please leave us a rating and a review. It'll mean a lot to us. The Pragati Podcast is available on the IVM Podcast app and pretty much every other podcast app and platform. We are there everywhere.
India's a massive subcontinent, home to truly stunning diversity. Behind the veils of smoke that obscure our thriving cities, our history is still alive, glimmering like sequins, waiting to be discovered. And if you, like me, are straining to hear the echoes of our past, this podcast is for you. I'm Anirudh Kanisetti, a history and geopolitics researcher, and I host Echoes of India, a history podcast about India, by Indians and for Indians. In Echoes, we journey through the complex histories of South Asia and what they can teach us about our globalized world. Tune in every Wednesday on ivmpodcast.com or your favorite podcast app.
How aware do you think you are of your laws and rights? Do you look up to laws when you are caught up in situations? Do you know what your rights are when you're stuck somewhere bad? Well, here's a show that can help you move an inch closer to being aware of what your rights are. Tune into Know Your Qanoon with me, Amber Rana. This is a podcast meant to answer all your law-related queries. Catch Know Your Qanoon every week on the IVM website or the app or anywhere you get your podcast from.